Good evening. Thank you for joining Research CP, an initiative to set a patient-centered research agenda for cerebral palsy. My name is Paul Gross, and I'll be your moderator for this evening. Our speaker is Amy Bales, and she'll be with us in a moment. I want to review a couple of things just to let people know, especially if you're joining, if this is the first of your presentations you're joining and whatnot, where we are. So we kicked off on March 8th, where we did our original, our first of our 5 in the series of webinars that are intended to educate everyone as a way to help them contribute to our collaborative community survey, which is running on Code Digital. We have over 250 people invited to that, and over 150 people, I do believe, are participating. Tonight is our 3rd webinar in the series, and it's focused on quality improvement. We have 2 more webinars, one each of the next 2 weeks. Our application process is open and started. You receive a follow-up email to viewing the first webinar, which has the link to that application and the post-webinar survey. So please get those filled out. Our applications are going to close on the 31st of March. And we'll get back to people and let people know who's been invited to the face-to-face meeting by April 10th. Couple other things I want to make sure from a housekeeping perspective and make sure people know. One is we sent out a summary for all people who either watched the webinar last week or attended the webinar live about clinical research. We realized it was a very technical topic, so we tried to do a couple-page summary that Michelle Schussman put together in conjunction with Dr. Susan Horn. So you should have received that. If you haven't received that, feel free to send me mail at paul@cprn.net, and I'd be glad to get that to you. Some other housekeeping issues. We are running things a little bit different tonight. I sent a mail just minutes ago with some backup links in case we need to use them. What we're doing is we're embedding video in our presentation. And so that is technologically, that's harder for a service like GoToWebinar. It's a beta feature of their platform. We tested it out many times because it didn't work at first. It seems to be working, but I may call on you to take advantage of that email I sent with some embedded links. It also means, because the way we're doing it, if you are dialed in by phone only, you are not going to get audio. The audio will only come through your computer during the embedded video portions of the presentation, which make up about 15 minutes of the presentation overall. It will be recorded, so there will be an opportunity to catch up if you have some challenges. So with that, I'd like to turn the mouse and keyboard over to Amy Bales and let her talk to us about the subject at hand. Let me make sure I've got Amy unmuted. And
yes,
Amy,
hello.
There you go.
Me. Can you hear me? Hi. Hi, everyone. And can everybody hear? Yes.
Yes, everybody can hear.
So,
go ahead.
Okay. Well, thank you, Paul and Michelle, for providing this opportunity for me to talk about quality improvement. Remember, the purpose of these webinars is not to make you an expert, but to build a common foundation for our whole group on a set of topics so that we can come together and create a shared research and quality improvement agenda for CP. We're going to start today's webinar with 2 videos. The first one defines quality, and another video, the second one, on how to make changes that can lead to improvement in quality. After the videos, I'll share a brief PowerPoint to summarize and build on the information from both videos. The first video will see Donald Berwick, who was the head of the Institute for Healthcare Improvement, and he's going to summarize the Institute of Medicine's report from 2001 that is still the gold standard that will introduce us to the dimensions of quality in healthcare that we would be concerned about. The second video is a little bit longer, by Dr. Mike Evans, who's a pediatrician and a health innovator from Canada. He has won several awards for his ability to promote and communicate science to the public. I think you will enjoy both of these videos very much. So, Paul, you can start the first video.
One of the most important things that happened in that report was it it gave names to the dimensions of quality. If you're buying a car, there are dimensions of quality: safety, fuel efficiency, comfort, fun in driving, durability, and so on. We're used to that. Well, what are the dimensions of goodness in healthcare? And the Institute of Medicine, Crossing the Quality Chasm report, gave us 6 dimensions and said these should be the areas for healthcare to improve on. It also summarized a lot of the research literature on the current levels of performance for those 6 areas. And here are the 6 areas. The first one is safety, back to the report from a year and a half earlier, To Err is Human. Safety means we're not harming people with our care. We're not adding to the burden of illness. So a safe healthcare system reduces hazards and risks from the care itself, safety. The second dimension they called effectiveness. And that was a term that sort of was meant to mean matching science to care. So if science says that this drug can help in this disease, then we use that drug. And if science says this can't help, we don't use it. So avoiding overuse of things that don't help and assuring use of things that do help, avoiding underuse, that's effectiveness, lining up science with care. There are big problems in effectiveness. The RAND Corporation famously published a study a few years ago which showed that of the needed effective care that Americans should get, when they tracked 7,000 people over 2 years, those people who had all sorts of things ranging from just well care to serious chronic illness, those 7,000 people failed to get 45% of the care that would have helped them. So that's effectiveness. The third dimension is patient-centeredness. And this is a pretty subversive goal. It means people should be in control of their own care. They should make decisions about what affects them. We say, nothing about me without me. It's putting the patient in the center of the care system and giving them power and control over their own lives and their own care. The fourth dimension is timeliness, which means avoiding delays. People are quite familiar with waiting rooms. We wait a long time to get to see the doctor in the emergency room or waiting for an appointment. In all other industries, timeliness is an important dimension of quality. You don't want to wait everywhere. Well, nor do you in healthcare. So timeliness is reduction of needless delay. Some delay is instrumental. You want to wait to see what happens, but there's a lot of non-instrumental, very costly delay. The fifth dimension is efficiency, which means avoiding waste. We throw out so much in healthcare. We give things that can't help. We duplicate procedures and tests. We lose records. We lose the ideas of the workforce by not inviting them to join in invention. So efficiency is a big word. It means stop wasting stuff. We're very, very wasteful in healthcare. The last dimension, which some people think should be the first, is equity. And that means closing the gap in justice in healthcare, basically. Right now, the biggest predictor of your health status in our country remains your race. If you know someone's race, you know much more about their future in health than almost anything else I could tell you about them. A black baby born in inner city Baltimore this year has a life expectancy of a male that's 7 or 8 years less than a white baby. That's a quality dimension too, equity. So safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. Those are the names of the dimensions of quality that the Institute of Medicine says we should work on. The Institute for Healthcare Improvement has taken those aims and put them in our mission statement. We exist to improve on those 6 dimensions. And more, thanks to the Institute of Medicine, you're seeing hospitals and clinics and health care organizations in our country, and by the way, other countries, adopt that same, now rather famous list of goals for improving healthcare.
Brought to you by the IHI Open School for Health Professions, an initiative by the Institute for Healthcare Improvement that prepares health profession students to lead patient safety and quality improvement in healthcare. For more information, visit ihi.org.
Hi, I'm Dr. Mike Evans, and today's talk is on quality improvement, or QI, in healthcare. So I suppose the first question is, why should you or I care about quality improvement? I mean, to be honest, it sounds a bit boring. Something a CEO would have on her or his corporate objectives. But actually, if you dig a little deeper, it's pretty cool. Maybe more of a philosophy or an attitude about how to make something better. And now that I think about it, it's really the attitude I'm looking for in my patients. the ability and desire to tweak their habits, seeing if this change improves their life, and if it does, to try and make it standard practice. You see, for my patients to make these changes requires skills, but it's also an outlook, the humility and self-awareness to say, I've got room for improvement, the ability to gather better approaches, try them on and see if they work, and then adapt them until they do. Well, if my patients can do that, I think they deserve the same from us in the healthcare business. So I suppose the next question is, if we have the attitude, how do we actually improve? How do we use QI to make care better? Well, the improvement business has been around for a while. Organizations like Toyota and Bell Labs and leaders like Walter Shewart, W. Edwards Deming, and Joseph Juran polished and simplified the science of improvement. And then along came a pediatrician named Don Berwick, and he wondered if we could translate the science of building better cars or electronics to healthcare. Dr. Berwick also wondered if there were lessons about systems we could learn from the kids he saw in his clinic.
The systems thinker is a perpetually curious person who never thinks they have the whole answer, but is always willing to know what the next step to take is. If you watch a child, you'll see this happen. Children in their growth and development are innately systems thinkers. They're always trying the next thing. They're probing the material. They're listening to the noise. They're thinking about what the next thing to do is, and they're not in the job of solving problems forever. They're in the job of taking the next step. I think those are elements of what it means to be a system thinker. At the core of it is constant curiosity about a world that you will never understand fully, but you might take the next step to understand a little better.
Okay, we've never dropped a vid into our vids, and Don is thoughtful, so I kind of thought it might improve our messaging. Let me know if you thought it did or didn't in our YouTube comments. Now, Dr. Berwick went on to co-found the Institute for Healthcare Improvement, or the IHI, and started focusing on the low-hanging healthcare improvement fruit, which is mostly reducing errors. For example, in Canada, a researcher named Ross Baker led a study in 2004 that showed of 2.5 million annual hospital admissions, about 13.5% were having adverse events, with 1 in 5 of those people dying or experiencing a permanent disability. In the U.S., the Institute of Medicine estimated that 44 to 98,000 people were dying from preventable errors every year. That's up to 4 jumbo jet crashes per week. Often these are errors we know how to prevent, but as is often the case, knowing what's the right thing to do and actually doing it are two different things. In 2006, Berwick and his colleagues challenged hundreds of U.S. hospitals to bridge this gap and felt strongly that some is not a number and soon is not a time, and so set the goal of saving 100,000 lives in 18 months. They started with this simple notion: every system is perfectly designed to get the results it gets. So how do you change the result? Well, you change the system that produces it. Changing the system requires change agents, and in my province we launched Health Quality Ontario. HQO and orgs like it recognize that it's tough to balance proactive and reactive care in the field. But if they can help or incentivize or nudge us towards a more reflective practice and improve outcomes, we can actually create a better user experience for us all. Now, making this sound simple, like pushing a button, but getting people to change, even a simple behavior like hand washing, can be very complex and exasperating. But these seemingly small behaviors can have a ripple effect on health. A 2010 study calculated inadequate hand washing caused 247 deaths each day from preventable hospital infections, and that's just in the U.S. So let's jump back to simplicity. How to improve seems to boil down to 3 questions in a cycle. Improvement starts by setting an aim. So question number 1 is, what are you going to improve, and by how much? So for example, we are going to get 70% of the staff to wash their hands before and after seeing patients by December 1st. Great. We have an aim. So let's start testing some changes, okay? Not so fast. Now you need to ask question 2. How will you know if a change is an improvement? We need to choose some things and measure them. What is doable and reliable? And that will tell us if the changes we are making are leading to an improvement. Is someone documenting doctor or nurse hand washing? Is it self-report? Is it the amount of soap and disinfectant used? Okay, we have an aim, and now we have some measures. Next up is question 3. What changes can you make that will lead to the improvement? To start, we just want to test one change with something called a PDSA cycle. Plan the test, do the test, study the test results, and then act based on those results. Maybe it's new soap dispensers or little bottles of gel. Maybe you read about the study that changed the signage from wash your hands to protect yourself to wash your hands to protect your patients, which resulted in a third improvement over a 2-week period. Maybe it's reward or audit and feedback or asking patients to check. Just pick one and get started. Then you test other changes and the PDSAs just keep rolling. Fine-tuning the change based on what you're learning. Saying to yourself, here are some ways we can improve. Let's try them out by dropping them into our practice in a thoughtful way that fits with our clinic and our patients. And let's measure how we do. Adapt, adopt, or discard. Simple, right? But powerful, and it actually works. At my hospital, St. Michael's in Toronto, elderly patients with fractured hips were often waiting more than 2 days for surgery. This wait was painful, with increased chances of conditions like delirium and depression, longer recovery times, and even death. The care team scratched their chins, mapped out and redesigned every step of the journey to surgery in order to fast-track these patients. They created a code HIP called as soon as the patient arrives. This streamlined them to the urgent list for surgery, rapid triage, essential testing, priority consults from anesthesia and internal medicine, and so on. All these tweaks led to a jump from 66 to over 90% having surgery within 48 hours. Now, these changes don't happen without engaging the human side of change. One thing you'll discover is that it's possible that the people you work with might not be as into hand washing or urine infections or diabetes as you are. I know, crazy, but this leads to 3 pieces of advice. First is the concept of innovation fatigue. Often your workmates are getting overloaded with requests for practice change, which are well-intentioned but can be overwhelming. My own approach is to take a page from motivational interviewing. MI recognizes some of our natural inclination as problem solvers is to fix things, provide advice, and argue for change. But the reality is that not everybody is ready for change. Both MI and QI recognize that ambivalence about change is normal, that building readiness and confidence for change, a shared agenda, requires careful listening and strategic questioning, the ability to roll with resistance, more of a dance than a directive, I would say. Actually, sometimes resistance to change can actually be an opportunity in QI. Creating diversity or disruption can actually be an opportunity, something to build on. My second point is about priorities. I think we have to acknowledge that patients and your fellow clinicians may have certain priorities on the day. That talking about depression or headaches may trump your diabetes flow sheet, or even that focusing on their non-diabetes issue might, in fact, be more helpful for patient self-management. These shifting sands that transition from silo care are the reality of the emerging science of complex care. Sure, asking what's the matter, but also asking what matters to you. A great example is in Timmins, a small town in rural Ontario, where they wondered if they could do a better job of handling complex patients in the emergency department. So people seen in the emergency more than 14 times or admitted more than 3 times a year. They started with standard assessment tools, identified diagnoses and related problems, generated care plans, but unfortunately, patient use didn't decrease. The team then flipped their approach to what's called patient discovery, where they identified health and lifestyle challenges from the patient's perspective and combined that discovery with motivational interviewing techniques. This new patient-centered approach resulted in more than an 80% reduction in emergency room use and admissions. Finally, after having done many interventions, my mantra is, how can I make it easier to do the right thing? Maybe easier is about sharing the load. At Kaiser Permanente, front desk staff can actually check and book for preventive screening. Everyone can help in QI. All these point to the softer side of good quality improvement. That when we look at the science of innovation, it's less about big cognitive leaps and more about agility and small incremental steps that build on the ideas of others and engage our own genuine curiosity regarding what motivates and inhibits the individual and system's path to change. The main point is, start. Find something you can improve and get going. Look, it's hard to summarize improvement and not get into bumper sticker territory, but I would advise not to let what you can't do stop you from what you can do. It's time to entertain complexity, but focus on simplicity, asking yourself, what can I do by next Tuesday? Have a meaningful needle and test some changes to start moving that needle towards an important goal. Hope this helps, and thanks.
Great. Well, thank you to everyone for sticking with us and watching those videos. I hope that you found them interesting and helpful. So the objectives I have tonight with my PowerPoint are to go through the dimensions of quality as they apply to healthcare briefly, describe how quality improvement differs from research, talk about the core questions critical to the model of improvement, and describe the important components of a clearly worded SMART aim. So we'll start with a quick review of our first video. Donald Berwick talked about the dimensions of quality. The first one was safety. We don't want to harm anybody. The second one, effectiveness. We want to match science to care. The third one, patient-centeredness. Nothing about us without us. It's a good way of thinking of that. The fourth one is timeliness. We want to avoid delays. The fifth one is efficiency. We don't want to have any waste. And the last one is equity, or closing the gap. Okay, sorry about that. There's a little bit of a delay. I apologize. So in the second video, Dr. Evans talked about some assumptions, and we won't talk about them all. But basically, we all have room for improvement. And in order to change something, we have to change a system. So we talked about the three critical questions when changing and making improvements, and those are, what are you going to improve? And in one of his examples was hand washing. How will you know a change is improvement? Well, you need to be able to measure it. And the hand washing example, the possible measures he talked about were the amount of soap used, was hand washing documented or by an observer, or perhaps it was reported as self-report. And the last one is what changes will lead to improvement. So you're going to test the changes that you think are going to lead to the improvement. In his example, his tests of change were using a new soap dispenser, perhaps changing the sign, or audit and feedback, where you perhaps are watching to see who's washing their hands, and then you're providing feedback to the people right when it's happening to let them know. Now, what's important in quality improvement is you don't want to wait around with a group of people talking about, well, what's the best intervention? Should we do the sign? Should we do the soap? Should we do the audit and feedback? You're not waiting to determine what is the perfect thing that you're going to do. You want to pick one and get started right away and test it on a small scale. An example of that might be to test new signage and then measure the hand washing on one unit in your hospital, for example.
Amy, let me interrupt for one quick second just because I'm seeing some traffic on the Q&A. So for people to get the slides so that you can see them, when you went to your browser, you minimized the application that is the Citrix application or the GoToWebinar application. It should be in your tray. If you click on it, you'll see the slides. So they are displayed. Go ahead.
Is that better? I just made them bigger. Can you see them better?
You didn't need to do anything. People needed to bring the slides back up by opening up the application again. So you're good. Keep going.
Okay, so hang on. There's a little bit of a delay when I advance the slide to when it actually happens. There we go. It's important to understand the differences between research and quality improvement. And probably most of you are wondering about that, seeing that we've been asking and talking about both of those things. So I'll briefly highlight some of the differences on the next two slides. To start with, research always tests a hypothesis. So you think something is going to happen and you're going to test whether or not that happens. Whereas quality improvement is really looking at a process, a program, or an entire system. Research really wants to move science forward. So the things that you're testing are beyond what currently is known about science. And that's very different. In quality improvement, we're looking at an established set of standards or things that are happening. In research, the subjects that participate in the study may be at increased risk beyond standard practice, whereas in quality improvement, there is no increased risk or burden for the participants, with the exception of possibly some confidentiality or privacy concerns. Both research and quality improvement involve systematically collecting data. Let me go to the next slide here. Hang on. I am so sorry. I don't know why there's a delay in that. There we go. The endpoint for research is to answer a specific question, whereas in quality improvement, it's to improve the program and the process. And a very important difference between research and quality improvement is that in research, all the data is collected, and then it's analyzed before we determine what the benefits of the intervention or the program were. Whereas in quality improvement, it's really, really important that things are ongoing and iterative, meaning that they happen over and over. Every week we measure something, every month we measure something, so that the procedures are constantly being improved. We're always testing and adding new things to improve what it is we're trying to improve. And then as far as sharing the results, there's a difference in who has the benefit with the results. In research, you share the findings with the individuals that are associated with the study and those not associated. Whereas in quality improvement, the benefit is immediate for the people that are involved in the programs. So all quality improvement starts with an aim or a purpose. And there's two kinds of aims that we're going to talk about today. The first one is global aims, which are general and overarching. For example, improve the care and health of all children and adolescents with Crohn's disease, or improve outcomes, experience, and value for families and individuals experiencing CP. After looking through Code Digital, one theme I noticed was that adults living with cerebral palsy have a lot of pain. A possible global aim directed toward that might be improve quality of life for adults with cerebral palsy. The second aim is a SMART aim. It's SMART because it's specific, clearly stated. It's measurable, so we know what we're measuring and what we're shooting for. It's actionable, meaning that it's something that's within your control that you have some influence over changing. It's relevant, it's meaningful to your organization, and it's time-bound, so you actually don't say, well, we're going to do this soon. We're going to do it by next Tuesday, for example. Some things that aren't a SMART aim are things such as, well, I'm going to develop a new program, or I'm going to roll out a new IT system, or I'm going to implement a project plan. Those are all things that you might do. Those might be tests of change that you do to achieve your SMART aim, but they, in and of themselves, are not a SMART aim. So writing a SMART aim is what we do to answer the first two questions discussed by Dr. Evans. The first question, what are we trying to accomplish? A SMART aim will help us determine that. And the second one, how will you know a change is an improvement? The SMART aim includes the measure, which is going to answer that part of the question. So examples of a SMART aim. Well, the first thing you see on your slide is basic template for writing a SMART aim. You're always going to start with, we will increase or decrease something, whatever you're measuring, within a certain group or population from X or your baseline value. And this baseline value is not a guess. You actually have collected information to determine what your baseline value is. So you're going to increase whatever it is you're measuring from that baseline value to another value. You're going to set a goal by such and such a date, okay? So an example below that is that the remission rate for children and adolescents with irritable bowel syndrome at such an institution will increase from, let's say, 20% as of June 1st to 80% as of October 1st. So that might be how we would look at a SMART aim. Let me show you a few more examples. So here's another example of an overall global aim to eliminate delays in our system and ensure the availability of the right bed at the right time at a patient admitted to whatever hospital you want to say. So this is improving a process, and a SMART aim related to that global aim might be to increase the percentage of patients discharged from a certain unit in the hospital from 65% to 80% by April 30th. The second SMART aim you see on this slide, it's not related to the global aim above, but it has to do with delivering certain drops into the ears during ear tube cases. So apparently they would like to improve or decrease the number of infections after ear tube. So they want to increase the percent of ear tube cases where these drops are used in the operating room from 35% to 80%, and they give you a certain date. So let's think about some possible SMART aims for CPRN, which I don't see the slides, so I'm going to talk about them here. We might say something like increase the number of centers contributing data to the Data Coordinating Center from 3 centers to 10 centers by October 2017. We might have a SMART aim that says something like decrease hip dislocations at a specific hospital from 50% to 10% by October. And we might write a SMART aim about decreasing infections from intrathecal baclofen pump. So let's go back to the Code Digital example I talked about with regard to pain in adults. We might choose to write a SMART aim such as increase the percentage of adults with cerebral palsy reporting pain scores of 3 or less on some measure of pain from 20% to 80% by September 2018. So we would want to increase the percentage of adults giving us a low pain score. So then we might test some things as what we think might help us get to reporting less pain in adults. So some things we might test would be exercise programs, pain medicine, other types of things. That's what we have to do together, is decide on those things. So all of this is going to lead to the work we're going to do together in person. What do we as a community want to improve, and how will we know an improvement has occurred? So I hope that, I believe is my last slide, I hope that this presentation has you thinking of improvements you would like to see in your care or your child's care, and that you share those ideas with us on the Code Digital survey so that we can, as a group, collectively decide what we think is most important. If this has interested you, I have put a few readings on the last slide. There's some suggested books. There we go. In case you want to read further on these matters. So thank you for listening, and I believe we're going to now open it up to questions.
We are. Thank you very much, Amy. That was great. And thank you, everyone, for bearing with the anticipated potential technology challenge. I hope that if I'm reviewing that worked as well as having it stream directly. So what I'd like to do now is just review how we're going to do questions. There's 2 ways to ask questions. You should see in the little GoToWebinar control panel a question and answer pane. A number of you have already posted comments about being able to see things, not be able to see things when you were finished and whatnot. So that can be used to post a question. And you'll see to the left edge of that panel, you'll see a little hand icon, and that is to raise your hand. So you can either click on the question icon or click on the hand icon to ask a question, and I'm going to kind of alternate back and forth. And I'm going to see if I can, let's see, and so what will happen when I ask, if I call on you because you've raised your hand, when I click on you, I think it will unmute you, or I may have to unmute you. I'm going to go with Maria, and, oh, I didn't mean to lower your hand. I want to let you speak. So hold on one second, Maria. I'm going to unmute Maria Stanley so you can ask. Go ahead, Maria. Maria, can you ask your question? Okay.
Can you hear me?
Yes, we can hear you.
Okay, no, my question was just about the videos, and I forgot to lower my hand. I apologize.
All right. You know what I'm going to do? Let me mute you again, and then I am just going to, because I think we had a lot of those as we were going, so I'm going to see if I can clear all the questions and let people raise their hands again. Let's see, can I do that? Doesn't appear. I'm going to take a chance. I see John Devlin had a question. I'm going to unmute you, John Devlin, and you may have also had a question that was from the video. So you are no longer muted, John Devlin. If you have a question, now is your chance. Okay, I'm going to go back to the Q&A. There's a question, is there any way to get a copy of the slides so that you can print them at home? Yes, in fact, they are loaded as a handout, and you should see that in the right-hand side, although Amy pointed out that we accidentally deleted one of her slides along the way. but you should be able to download that right there. If you click and open up that little thing, you can see there's a PDF of the slides for you to be able to download, but I can follow up with them as well. So let's see, we also had a question at the very beginning, which was, how are the questions in CoDigital matched for ranking? Some of them don't seem to be equally matched. So I'm not sure that I know what you mean by match, but I think my understanding of the way CoDigital works is it pairs them not to necessarily always match 13 and 14 to see which one you want to have one bubble up. It kind of compares them, and then it reveals to you what they were ranked. And it does this repeatedly and to everyone involved as a way to establish a ranking. And I can get more information about that ranking system, but it's the analysis that we did up front was it was pretty highly regarded for being a mechanism for doing prioritization. We will look past the line where things are being presented to people during the workshop as part of our prioritization system. Probably not down to 80, but certainly below 20 or 25 wherever things are listed. Okay. Let's see. Should we be able to see the questions in the chat box? I don't think the questions come to the chat box, but I do see some other hands being raised, so I'm going to go, and in fact, I think it was Amber's question, so I'm going to unmute you, Amber, and you can ask your question. Okay, I'm not getting you now. If you're muted on your phone, I can only unmute you on the webinar software. All right, I'm going to move to Patty Lyons, and I'm going to unmute you, Patty. Have a question?
I do. Are you able to hear me?
We are able to hear you.
Okay, great. Just as we've been going through this, I've been wondering, I feel like everybody comes into this with their own kind of inherent biases based on your personal experiences. For me, my daughter has severe CP, and so I kind of, my opinions are slanted towards that. I'm wondering, people who are kind of the ultimate decision makers, who are going to consolidate all of this and move forward, what was your starting point? What are your current beliefs about what we're doing now or what's happening now for you? What do you think is working and what's not working?
Paul, do you want me to start?
Yeah, and I mean, let me just make the statement that there are clinicians that can answer that, and I'll let Amy take that from that perspective. But just to be clear, the whole idea for this was to start with a blank slate and for us to gather a sort of a balanced view from clinicians and from the community. And so that's really what we're hoping to capture, because, clinicians see what clinicians see, but you experience what you experience. So go ahead, Amy.
No, I agree totally that the purpose is to get the community's thoughts and ideas on what is important to them, not necessarily what the clinicians or the people looking at all these answers think. There are people, Michelle Schusterman, and there are people that when we all come together will be mostly community caregivers and families. We have thought a lot about the fact that, yes, your things that you think are important are based on your own experience. So children that have severe CP may not believe the same things are important that children who have, at a higher functioning level. So we're aware of that, and we've talked about how we might talk about themes that either cross all levels, or how we could look at different age groupings or different functioning levels, because I do hear a lot from families. I'm a physical therapist, that we spend a lot of time on certain groups and not enough time solving problems for other families with other groups of children. So we hope that we could get your input through CoDigital. Does that help?
Yeah, it does. I guess one of the things for me that is so challenging, I think, in seeking care and moving forward is this belief of worthiness. You know, that if there's a certain level of ability, a certain level of cognitive ability, that at some point in time they're not deemed as worthy and worthwhile. And I feel like that's a huge bias that you have to overcome to even get access to what's out there and available for your kid.
Right.
And I haven't really seen that on the co-digital or, you know, in the threads. I haven't really seen that expressed yet.
I think that would be a great thing to suggest. I mean, it might be tricky and it might take a couple tries to phrase something that would capture it, but I think you would find there would be a large swath of people that would find that to be an interesting topic. So thank you.
Yeah. I encourage you to think of ways to express that, perhaps think about what do you feel is valuable to your family and your experience, and try to put that down in words, because I think what you're saying we hear a lot of, and we want to help. We really do.
Great, thank you.
Thanks, Patty. I'm going to mute you, and I'm going to go on to, I have a sneaking suspicion Ed wants to comment on that, so I'm going to, let me just check and see, and then I've got a question. I'll let you start to think about this next question, Amy, which is, there's wide variation in individuals with CP, so how will the QI concept be generalized? But let me just see if, Ed, were you hoping to weigh in on that question, or did you have another question?
I was hoping to say something about the question.
Go ahead, please do.
Okay, great. Yeah, so what I've noticed in the co-digital is that the questions, the responses that seem to rise to the top are those that cross all of the GMFCS levels. People ask about what interventions work across GMFCS levels and that sort of thing. And I think the group that is participating, the group here and everybody else who's participating is showing a bias toward wanting to help everybody, to the point where sometimes when more specific questions, like our questioner is asking about, come up, they don't rise to the top because they're put up against something that's more general and helps more people if we could actually address it. So I think that may be some of the feelings that we're having, and some of the discussions that our leadership group has had about, do we need to divide this up a little bit more, maybe have one set of questions for children, one for adults, one for one GMFCS level, one for another, and that may be something that could help in this situation.
Thanks. And that's a great point. That is an active discussion that we're having about launching a few more questions where we basically can say, we've got these very good generalities about what people like to see improve or questions they'd like to see answered. Now we're going to ask you to specifically go into these couple areas. So we're going to keep co-digital open. The engagement's been great. I greatly appreciate it. I know it's a lot of voting, but it's been a great way to sort of get, what those generalities are. So we're going to look to see if there are a few things that can be consolidated because they're, a little bit repetitive. Make a little bit more room, but then we're also probably going to launch a few more questions where we ask you to say specifically about either GMFCS level or level of severity or whatnot. So, Amy, I want to turn it to you to answer the question of, is there's wide variation in individuals with CP, so how would the QI concept be applied?
Right. Very good question. So there's several ways to approach that. And I'll list a couple in my mind that I'm thinking we could do. Number one, we want to look at things that we think are going to have a high impact, whether that's because they're it's a safety issue, it affects a lot of people, it costs a lot of money, it affects quality of life, whatever the community decides is most important. So we want to try to look at those things. We also want to look at things that may cross a wide group of people. But on the other hand, we could also, within the network, the CPRN network, we could have two centers that want to focus on a QI, an improvement that involves adults, let's say, with pain, and we could have 2 centers work on something that affects children and families that have kids functioning at GMFCS levels 4 and 5. So we could have different projects within the network going on at, a couple centers, and then go from there. So those are some ways we can address some different topics with quality improvement within the network.
Okay, thanks. Next question is going to be someone's raised their hand, and it's Nancy. I'm not going to butcher your last name. Nancy, go ahead, Nancy. If you are unmuted on your phone or your computer, you can speak now. And since I'm not hearing you, I'm going to assume technology.
Hi, can you hear me?
There you go, Nancy. We can hear you. Go ahead and ask your question.
Hi, Paul. I think one of the prior speakers helped me to understand. I've submitted a lot of questions, and none have come up for a vote. And personally, I think some of what I submitted was good. I'm an adult. I'm 51 years old now, and I've lost so much function in the past 2 years. It's mind-boggling. And I'm from Pennsylvania, and there's like no doctors to really explain stuff to me. So I go and I look for stuff, and there's scant information. So that's why I decided to join this. But I was having difficulty understanding why none of my questions seem to come up for a vote. They all get booted off Tier 1 islands, so to speak.
So
mine, Nancy.
Nancy, let me, as have mine, and I've worked hard to phrase them. So let me take that as an offline thing and try to get questions more directly related to our QI for now. But I understand the issue, and I know you and I have exchanged some mail on that. So thanks. Let's follow up in email.
Thank you.
There is a question about from Maribel. Are we going to focus only on medical or education opportunities as well for children with CP?
Well, that is a great question. We're going to focus on whatever is most important. We could focus on education. We can focus on employment. It's not all medical. Whatever function and participation in life is our goal.
Yeah, the thing that I would add the caveat of to the degree that CPRN, so there is the agenda overall, and then there's CPRN, which is focused on clinical research, could pursue a question in that range, but CPRN is not the only way to get these questions answered. So,
I mean, one thing the network will not have is we will not have education. We will not have information on the children from their school. So that isn't a part of our network where we're gathering information from that, from those places. So I don't know if that helps in that question.
So the next question is from Amber Gorman. Amber, you are unmuted, so go ahead.
Yeah, what I meant by equally matched is that, like, for example, say there's a question about an orthopedic surgery, and then it's matched with something that's not another surgery. I'm just trying to get clarification on, like, does it pick out keywords?
No,
or
I don't believe it picks out keywords. I think it has I can get you information about the algorithm. It has a mechanism that is intentional. I just can't describe it. I know our facilitator talked to them and was very impressed with, because she's going to run our group process. She was very impressed with their algorithm. I didn't get the details on it, so I'll get back to you on that.
Okay.
Okay. But I know it's not I'm pretty sure it's not keyword based. Okay. There was a question, and this, Amy, I want to be cautious of time. We're at 9 o'clock. We have a few more questions. Are you okay staying on a little bit longer, or?
Yes, I'm good.
Okay.
I'm
so
good, thank you.
Rochelle asks, what if you live near one of the centers that is working on a question that doesn't affect you, and the other center is working on what you care about, is across the country? So do you want to talk a little bit, explain that in terms of sort of implementation and why that's a perfect question, Amy? Did you understand that?
I think
You want me to take it and you can correct me if I'm wrong?
Yeah.
So
Yeah.
Michelle, I think what the beauty of this is, especially with a large network, is if you look at Ohio, where they have a safety-oriented network, and they have so many sites in the network that some sites work on one question and other sites work on another question. But once they get to the point that there is evidence, either QI results or evidence from like clinical trial, then they roll it out across all of the sites that are participating. So the bottom line is you get the benefit even if the question that you care about is happening at another center. That's different than if there's a clinical trial that you were hopeful to participate in. But from a quality improvement as a way to roll out, evidence-based care broadly and get outcomes to improve, I think that would be a good thing from that perspective. All right, I don't have new hands raised, or maybe I do, but let me see. If the center focuses on a certain subpopulation for QI, then it would be open to individuals across the country, and if so, will the individuals have to travel to face-to-face, or can they participate remotely?
Mm-hmm. I think that it seems like from these past two questions, people are thinking that quality improvement involves an individual participating like you would in a research study as a participant, and that isn't what happens. The care happens at that institution as it normally would, and they're working on processes to improve the care for the people already being seen at that institution. So it's not like a research study where you are a participant in a research study. Paul, do you have anything to add to that?
No, I think that's great. I think that characterizes what I was trying to say, which is, so I think that's great. I think it's if you go back to Amy's slides about what's different about research versus QI. QI is the practice, is established practice. Everybody's involved in it if you're at a site that's participating in QI.
Let's say you live in, I think that's a really great question. I'm really glad that you asked that. Let's say you live in Connecticut and you're really interested in a study, a quality improvement project they're doing in California. Well, we will assume that there are people in California similar to you that get care at that institution, that we will see how that project, how that improvement affects their care or their outcomes, and then hopefully the institution you're at will then, we will spread that improvement to that location.
Great. So the other questions are about CPRN sites and whatnot. There is a comment that I think that I think we all take to heart, which is they like to see some discussion of employment if possible. But again, I would also recommend that you post a question on CoDigital. Okay, I think at this stage I'm gonna wrap up. Amy, I want to thank you very, very much for putting together this presentation, finding those great videos. Everyone that's on the call, thank you for your engagement and your patience with our technology challenges. We hope it worked out for you. We will be doing the usual follow-up. When you hang up, you're going to get like a 5-question survey. Please do it. It does also appear in the follow-up email that happens in like 24 hours or so. If you don't get the survey, I will send it in another form, but I wanted to let you know that that would be there, and that's important for us to understand your engagement for tonight's presentation and a key element of the application process overall. So thanks, everyone. Good evening.
Thank you so much. Have a good night, everyone.